Hi everyone, and welcome to another edition of this audio podcast series on the molecular the molecular storm gauge. And today I'm going to be talking about or highlighting focuses around population health and grouping vasculatures. And this is another Storm Lobostic production, and you know who it is. It's the Shientist. And I'm going to break this down into 2 or 3 segments or sections. There's a bit of introduction, a bit around a bit more understanding about population health and the dilemma, and then and just bring that the whole discussion into a summary. And just to let you listeners know, everyone know that this is a link to the last podcast, audio podcast, which was focusing on the science and the healthcare multiverse. And so let's crack on and get to it. So the introduction about this. So what's this all about then? The use of the internet or social media use doesn't suit everyone. It doesn't people do not always find it easy to navigate or find different sources find access to information or even educational support through different ways of navigating different aspects of different sorts of social media. And even if people are using social media, it's not always helpful. It's always there's more focus on brand and image, and those sort of entities, rather than actually educational focus. And I think all listeners know that. So however, patients whose first language is and especially actually patients whose first language is not English, for example, approaching the internet and even as social media, and the dynamics around how there's interplay between the internet and social media usage. There can be ongoing conundrums and dilemmas, etc., and that impounds on areas of health literacies, and we all know that, and I've mentioned that in some things in some of the podcasts or audios before. And there will be and what happens if there's impact on health literacy and barriers around aspects of language. Even those whose language first language might be English, for example, they can still find challenges, or there can be challenges, because there's differences in how different perspectives around different terminologies, and even aspects of literacy. For example, I'll give a basic example here. For example, if you type in, let's say kidney disease or long-term condition, and you put that in Google Translate, for example, in a particular in any other particular language, from English to another language, for example, or vice versa, whichever might be preferable, it might not mean exactly the same thing. So that can be a hindrance, it can be a barrier, etc, etc, and it actually puts off people approaching aspects of healthcare more generally. Right. Now, from there, using having that understanding, and it can impede, and predominantly is a problem. Generally, I'm going to say outright, it's a problem on population at population level, and actually more globally, because this actually, when you think about it, and especially in the areas of healthcare and that perspective, and as you know, the Shientist is all about talking about healthcare services, research, and on all of that academic good stuff. Basically, with this construct in mind, and that construct in mind, what should be understood here is also that it also impedes in our general communication, in how we sorry, one person wants to communicate with someone else, and and even potentially groups of people want to talk to each other, for example. And I'm talking about, for example, patients talking to professionals, and professionals talking to patients, and vice versa. So basically, in a nutshell, as in some way or another, there's an impact, and basically a black hole is created. A black hole gets sort of created because no one gets answers to particular questions, and that's an ongoing problem. Now, if we crack on from there, there then is health literacy, for example, is predominantly a skills-based construct, and that does and it does not actually include, at least from the literature that I've come across, apparently it does not include motivational elements. So that means if someone's looking for some information or trying to identify information, it's because out of necessity, more than the reason, more than the intention is around that they're motivated to do so. It's out of necessity. Like, so for example, say someone's about to get their back broken or something like that. They need to find out where to get what part of their back is being broken, for example, or what hurts. Then, for example, or maybe their arm is going to twist or break, or neck is about to break or twist or something like that. So basically, in obviously preempting any of those situations, or that situation, that sort of let's say sort of pains that relate to osteoarthritic or osteoporosis type conditions, then basically it's out of necessity that people need to find out information and how to sort of approach areas of healthcare in that context. So using modes to improve health literacy alone to determine the needs of patients, and simplifying sort of educational elements or focuses for them as a result, may be a barrier to those people, or might be a hindrance in some way or form, because even though there might be every sort of all the kinds of resources are available to access information, it's down to having the premise and the intention to actually sort of gauge with the resources and information, and then obviously if that is not being achieved, it's because there would be barriers and hindrances between, again, communication elements between, and sort of interaction between patients and professionals, and vice versa, and so thus ultimately causing a problem in the and I'll say that the causing a problem between the professional and patient relationship, and actually further still, is actually it causes an outright debacle of health care, and healthcare and healthcare professionals, and everything that they think they stand for, when actually they don't. So as such, patients may gain some of the understanding. However, that does the issue again on this premise is that they don't have the mindset to act, and that is where I've heard this phrase before, I think, and maybe listeners have heard this, where action reflects leadership. And that is the problem with healthcare professionals. There is actually outrightly and all around robustly, there is no leadership. So there's some context around that, and it's actually quite eloquently put by works by Barnett and his team and that team in 2012. Now I'm going to carry on and just give a perspective on the National Health Service perspective. So the NHS, by seeking health through the eradication of certain types of conditions or diseases or health ailments, etc., etc. And by the way, when anything is sought to be eradicated, it's about that there is such a thing apparently in literature that refers to a perfectionist model, and that is something that has been envisaged. And of course, if you eradicate disease, then that's an ideal, in an ideal world, that is a perfectionist model. But actually, at the same time, if we use our sort of our sort of our grey matter and apply that a bit better, a bit more focused, with every sort of disease that might be eradicated, then there might come out of that something else. So listeners, at least have that in mind in some way, because what happens then is there's a built a sort of a growth and built-in factor, which inevitably leads to basically broader and perhaps more expensive sort of areas of medical service or clinical services, and actually between healthcare sectors, between frontline and actually but between those services in healthcare in community and in secondary care. So and this from the UK, from the NHS perspective or National Health Service perspective, that has actually been sort of retrospectively, if we were to sort of audit or backtrack areas of services between different sectors, dating back to 1948, for example, the time and the conception of the when the National Health Service came to be. Literature and one paper in particular, I guess, and there are others. What can be learned is that patients living sort of who have certain health conditions or health complaints, this one paper highlights that patients or those suffering with particular conditions or going through long-term conditions and so forth, they desire sort of pragmatic and predictable interactions with health professionals, etc., and search for more knowledge. That is, if they are actually gauging and also apart from seeking out appropriate knowledge and understanding, that they also just like how, for example, health literacy is at least in literature, it highlights. And by the way, I'm no expert in this, but in trying to understand aspects of health literacy, where health literacy when patients or individuals want to seek out information around particular conditions, for example, or particular areas of healthcare or research, generally speaking, then it's not a as mentioned by the paper by Barnett in 2012. This is highlighted that it is actually out of necessity and not and it's not, there's not a motivational component behind that. And so and so just like using that understanding and context and example, then that also means that those who seek out information to particular areas of healthcare, for example, then automatically as well, they gain the knowledge, they become empowered, and actually take on, if not take ownership, they take a responsibility to gauge with and interact with areas of healthcare and between health sectors. And that's been highlighted by context that's been highlighted by Smith and team in 2014. Now, it is possible to inform and interact to interact where for patients to interact and professionals to interact from all walks of life and sort of all educational backgrounds, if provided with well-designed educational information materials and given appropriate decision support by well-trained health professionals. And that doesn't necessarily have to mean frontline health professionals and patient. And that's some understanding that's come out of a paper by O'Connor and team in 2009. Importantly, more evidence, though, however, has shed light that people with low literacy levels or health literacy tend to defer, not tend to automatically refer to health professionals on the front line to make decisions for them, and tend to have and what happens, unfortunately, they can have poorer health outcomes, or if not poorer health outcomes, they definitely, sorry, I probably shouldn't say definitely, but I would say in a balanced, with a balanced understanding, I would say that they would have poor experiences in healthcare, and than at least than those who are perhaps more active or proactive in areas of in healthcare and across areas of healthcare. Now, let's get into the crux. That was just a bit of the introduction on this. I'm not going to get into the crux of this. So, population health is becoming more of a focus in today's health in today's society. We've all had to face, the grim realities and the failures around, COVID-19, the pandemic, around the restriction, some groups of those in certain with certain areas of healthcare compromise, etc., etc. Make no mistake, they are actually the ones who win in the end, at the end of the day. But so that we're not going to have a particular debate. Let's say, for example, that that there is a bit of a problem in at least where there seems to be more of an economical gain for those who are, for example, I'll use the words quite loosely, and that is to say, are used to sort of earning wealth and having a livelihood, earning wealth for livelihood, and that is to say, that is in so much to say that, for example, they might not have health complaints, and they perhaps have not had to abide by certain COVID-19 restrictions and guidances, for example. So first announced, though, however, in 2003, the term population, or the terminology population health, was used to describe the health outcomes of a group of individuals, including in the distribution of such of particular around particular areas of healthcare and outcomes, and that's been highlighted in a report by the King's Fund. population health has actually now progressed to include areas of sort of methodology for identifying people at risk of particular conditions, and areas of areas where groups of patients, where patients or areas of healthcare could benefit from particular clinical trials, and intervening or having interventions for prevention or prevention sort of developing comorbidities, and actually other focuses. So if we're looking at sort of population health, and looking at, you know, sort of the I guess the fenestrations and the vasculatures around this, grouping populations according to conditions, severity of illness, demographic qualities, and or other parameters to identify risk levels. That can also help those. It helps, and it also is positive and negative at once, and that is to say that causes a leverage on resources to improve healthcare and outcomes, whilst in attempt to reducing health inequalities. Now, that's some additional context that's come out of the King's Fund report in 2018, and whilst there is strive by health professionals to do such things, what happens is it does become health research, healthcare and research focused. But the issue is here, listeners, is that actually what happens, it is actually the health professionals on the front line that ultimately benefit in aspects of healthcare, and then further from that, it is aspects of those involved in policy who also benefit. And I'm perhaps not saying anything different there, but it's important to sort of have that understanding, for at least from this sort of archetype. And now I want to just highlight about go into basically a bit more about, apart from highlighting population health issue and focuses from sort of a basis. I now want to go into the sort of do what I can to bring some context around population health and the sort of the ongoing concerns or dilemma. So the focus of population health is also on or has retrospectively been a focus on strengthening primary care, that is community medicine, and those health professionals on frontline, as in the community, and delivering care closer to home, which is consistent with at least current some of the UK current policy of integrating care to address growing demand and pressure, and sort of in an attempt to alleviate sort of supply and demand issues and pressures in some way. That's some understanding that's come out of in the King's Fund report 2018, but also in a report by the NHS long-term plan, or long-term care plan, which was published in 2019. Population health balances the incentive management of individuals in the greatest need of healthcare with preventative and personal health management for those, for example, who have lower risk those with lower risk levels. But and in that context, accountability for populations' health shared across shared in and around between sort of health sectors and organizations and communities with the sort of drive to sort of intervene and sort of target where focuses can be addressed to alleviate burden. And that notwithstanding, the point on this perspective, there is then a requirement that apart from addressing that or those things, the health needs of the population and the sort of underlying or underpinning sort of entities should, if addressed appropriately and accordingly, should also alleviate disparities and determinants of negative determinants of health. So that is also some context that's sort of that's in literature, but do refer back to the National Health Service long-term plan published in 2019. There is now ever more need to improve areas of integration for people with certain health conditions or health concerns and dilemmas, and this remains one of the most important challenges facing society. And that has been highlighted in a previous audio podcast. But this concept, the understanding, go back to the main resource, which was the King's Fund report in 2013, improving care for people with long-term conditions or ongoing health detriment sort of should involve a shift really from reactive and fragmentive to one that is more proactive and holistic, more inclusive, more diverse, and actually one that is more compassionate in a way where people are encouraged to be more involved and play a central role and to take ownership, so that actually healthcare doesn't just become a terminology. It becomes centric, and that's what's sort of been highlighted in literature, also by Prainsack, Sivan and Pratt, and a fair few others. So since the 1990s, latterly primary care medicine has focused to work in line or focus in line with the Department of Health, which promoted what is referred to as the sort of the cycle of commissioning, and that is there's various ways that can be kind of approached, but ultimately where primary care medicine is and has been, it focuses on a link between what is also referred to as quality. Is what is referred to as QOFs, which means quality outcomes frameworks, and those quality outcome frameworks, or QOFs, have traditionally or retrospectively been related to how patients or people with different conditions, and it could be something, someone's broken their finger or something as basic as that, and how that's coded into in and around a part of patients' electronic patient records, and then from there, that is actually based on that, traditionally retrospectively, is how, for example, GPs and physicians in primary care get paid, and basically from there, then if coding and understanding codes and aspects of healthcare and medicine, and from that perspective, and actually in areas in secondary care. So once, for example, patients are admitted into hospital, admitted into those settings, then that's when, in literature, for example, it's a little bit disturbing, but shouldn't be no surprise. That's when literature says that, for example, certain groups of patients are a burden to healthcare more generally. So so, for example, I've thrown out a few sort of understandings in previous podcasts, but for example, those with cardiovascular disease, so those with type 2 diabetes, those with hypertension or high blood pressure issues, and those with maybe areas where they've got chronic kidney disease, or even acute kidney injury, and sort of relapse and remission episodes around acute kidney injury, and other areas, other focuses around healthcare. So QOFs are basically coded focuses where those in frontline practice can get paid, and then once that happens, and this cycle of commissioning, and where that is concerned, that is actually how basically, to be quite blunt about this, is how patients should be getting, it should be the cycle of commission really, when it first sort of developed, and it is part of a particular framework, when it first sort of came into sort of the mainstream, at least in the UK, and in community medicine, it really was actually to ensure patients get sort of the best kind of care, depending on what's happening with areas of their health. But ultimately, what happens is that the health professionals in those areas, once they know and can see the kinds of for example, I'll give this scenario. If something is coded coded according to what a patient comes into a kind of a GP surgery, or a surgical a primary care surgery, a GP surgery setting for, and say, for example, I don't know, again, for example, let's say they I don't know, probably an extreme example, but I'll say this, their neck hurts, and basically there's like, it cracks or something each time they try to move it or whatever, and they know that someone will assess that, and they say that basically they might need an x-ray. But apart from that, they may those particular symptoms will align to a particular QOF, and it might be one or two QOFs. and this is the cough is still used in between healthcare sectors. But what I would say is that I'll be quite blunt here. But for example, if anyone, any listeners out there, if they knew, for example, that the coughs are attached to certain codes, codes that align to QOFs or quality outcomes frameworks, then what happens is that and for example, if you see for example sort of money or finance figures attached to those QOFs, then I'm sure in some way, like most people, your eyes will light up with the sort of cartoony money signs. Then it would just, your eyes would just keep spinning with those different kind of money signs. So on that basis, once that is known, then obviously it's how then apart from making sure that patients do benefit out of what they need and require, which does obviously, it requires a sense of integrity and rigor, but apart from that, it's where health professionals can quite easily fall into this thing where fall into this sort of this routine where when because they know how things are coded, they could also get an understanding of when they, for example, how much they might get as part of their next salary, when that is calculated, and they can become sort of hoarders of aspects of health. Health when they know, for example, by more or less always the whilst I say it quite bluntly, the cheapest option is used to address aspects of ill health, that also can cost patients lives. And that's something that health professionals still find baffling for some reason, and when it's actually quite common sense. And it's because what happens is more or less, and this is in literature as well, in literature, when in sort of interrogating and investigating in more deeper, it highlights that there's other ways to actually use and implement and spread actually that wealth, so that there really is patients do really benefit from that. That's a bit that's some entity and focus around what is known as the clinical commissioning, the cycle of commissioning, and it was in 2000 for example in 2013, that was sort of replaced by new so in April 2013 it was replaced by just over 200 statutory clinical commissioning groups, but which also focus on QOFs, but take on similar responsibilities. Now they're also charged with funding and planning and procuring health services to meet the needs of a local population. And there's quite a good paper on this by Shaw and team in 2013, and uh, I will give I will look to give the full reference after. Um, so in summary, I'm going to say that the complex and nuanced nature of commissioning, I mean, it's generally a problem if patients are not able to navigate and health literacy and language and all of that stuff is part and parcel of the detriment, because actually patients unfortunately retrospectively and traditionally have always looked to the professionals to get the answers and get aspects of healthcare sorted, and there's nothing wrong with that, but over time, you see, and I think well, I don't want to say I think because as you know, the Shientist is all about bringing that evidence and making sure that it's all, you know, all above board and in keeping. So basically, retrospectively, research highlights that that there have been some ongoing challenges around this, because different apart from the cycle of the cycle of commissioning, how that sort of came into effect. There's other models of contracting, and such context has areas of accountability and sort of provision, and focuses around alliance contracting as well, and basically the sort of nuances that come into play, or a part of that interplay, then can make it that much more challenging for, unfortunately, the general population to actually navigate healthcare more so. Or if not navigate, the navigating might become that much easier, but the hoarding of wealth can still be problematic, and so in line with that, if pathways, if certain, if there was sort of that, again, that educational focus, if that's back into it is part and parcel and part of patient care, you know, and really like honed in as a fundamental, then basically the pathways between healthcare sectors, etc., can offer patients an appropriate balance of choice, and providers can ensure that there is reassurance and more integrative practice between health sectors, and that interplay also focuses on the fact that that health professionals between health sectors, both those who work sort of behind the scenes and not that have sort of that understanding, but as well as their sort of practical skill base, can offer you know, support, where health professionals on the front line, they know that they struggle, but they they have traditionally, again, used their skill base to their sort of to their advantage, you know, sort of, and that's sort of the underpinnings here in this in sort of where we are in line with where we are in sort of 2021. At the heart of this, there should be a sort of a crafting of arrangements or effort really, that ensures that providers are sort of uh, able to coordinate high quality and safe high quality of care and safe practice, while avoiding the risk of sort of monopolizing a provision that compromises choice, and that's the problem in areas of today's practices between health sectors, because whilst it should be about patient's choice, if someone's about to, for example, break their neck, for example, albeit there's probably a bit of a, again, probably a bit of a, so apologies to listeners, it's a bit of a extreme example, but if someone is about to break their neck, but it's not quite broken, the choices a patient might have, or individuals might have, is have an X-ray and get it sorted, or go basically take some painkillers, and in the hope that the pain will go away. And what often happens is that in healthcare, in 2021, when the symptoms are obvious, that maybe, for example, that someone needs surgery, for example, to fix that issue, then someone in frontline practice will probably say, if you take some painkillers, rest a bit, it will be okay. That is the sort of the effort, the extent of healthcare practices today, and some of that context has been highlighted in papers by Smith and team in 2013, and Petsoulis and team in 2015, and perhaps not in such a blunt and sort of fast way, but in context, they put it quite more eloquently. However, if the UK, if healthcare in the UK is to improve its and I'll use this terminology, its elegance in future, it needs to have a clear, there has to be transparency and defined sort of remits against which aspects of quality, safety and progress can be measured. And that's not to say that that hasn't happened. Of course it has happened, but listeners are from what I've said, that for example, healthcare professionals are the ones who actually win at the end of the day, and that shouldn't come as any surprise. The role and remit, the role and remit need to set out roles and the remit around sort of areas of practice should be set out by healthcare professionals to a point where there should be more integrated practice, where health professionals between healthcare sectors and patients can actually sort of focus aspects of healthcare, so that so there's a win-win situation on all sides of the paradox. And as part of this as well, the NHS and any sort of, like, for example, commissioning boards and how they come to be and how they focus must be articulated to patients and the public. And again, some of that context is highlighted by Smith and team in 2013, and Petsoulis in 2000 and team in 2015. Now, what I'll say is that that is where there is a focus around patient and public involvement in aspects of areas of practice, but really and truly, to understand how successful, or how how they really function, no one really knows. We know that, for example, the one thing we do know, or what is known, is the National Institute of Health Research, or NIHR, and there is some guidance by, I think, the National Institute of Care Excellence, or NICE. There is some focus around patient and public involvement, and there is there are examples of what sort of patient and public involvement, sort of health and sort of research could and should look like. And I've mentioned one that example in previous podcasts, from at least the nephrology perspective, and that is to say, the renal patient support group, or the RPSG, and also the kidney disease and renal support, group for kidney disease and renal support group for kids, or KDARS for kids, and they're involving patients to kind of get an understanding of where gaps in healthcare just really outrightly need to be met, and it's sometimes the most basic things, like, for example, from the literature, lots of these individuals or people, as I've come to know, and read some of the papers as well around this. People do worry about, or have these anxieties about, sort of, especially around sort of focuses where they feel, for example, there might be urinary tract or bladder complications and things like that, and they don't seem to know how to sort of, if not navigate areas of healthcare, they don't know how to approach certain aspects of sort of the healthcare between health sectors. So, for example, if it is related to the urinary tract, and maybe such patients are under, for example, a nephrology care, for example, then my understanding is that they would have to go to their nephrologist, but that focus might not be universal from one region of the UK to another. Even if they're under nephrology, a nephrology service, for example, they may have to go to their GP first, and that then becomes this whole thing about quaffs, and so it just gets really messy in that context. And some patients know how to address that, and basically the renal patient support group, as far as I understand it, have done quite a lot to bridge some of those confined areas of those confined areas of where there might be inequity in aspects. And I don't want to go into the business aspects of this, but it's basically and unfortunate that healthcare is very much about business. And when I've understood from for example, works by Mohammed and their team, since at least from what my readings have been, and the literature, they're saying that there have been issues around different aspects of healthcare, and it seems quite obvious that educational focuses could actually look to sort of integrate practices that much better, but unfortunately, health professionals and patients don't always sort of cannot always have those have interact and agree on certain areas of healthcare. And again, this is because there are various hindrances or barriers. And so patient and public involvement has stemmed from Involve, which is part of the National Institute of Health Research, and it stems back before 2014, but 2014 was actually, from my understanding, there was a major conference that took place in Birmingham. I believe it was in Birmingham. If it wasn't Birmingham, it was London, and they highlighted various aspects of patient and public involvement. And again, there is a sort of an important role, where patients who are sort of more proactive or activated, that is, who recognize that they have sort of the confidence and sort of skill base to sort of address areas of practice, or actually sort of navigate and sort of provide a bridge between health sectors, etc., etc., then the evidence sort of pronouns that the skills can be developed and strengthened, even among those who are initially, for example, less confident, and actually might be. I'm gonna use this word, and I don't know if listeners have heard of this word, heard of a word that sounds similar. But for example, there's this word I'm going to use is sort of immunoliteralized, and that's basically a word to say that those who have sort of a sort of compromised literacy levels, and around health specifically, and particularly, and where, for example, immunocompromised relates to those, for example, who have weakened immune systems. So there's context around sort of the focus around and evidence around, sort of strengthening sort of areas of practice, and bringing more bringing a link between those who know how to navigate aspects of healthcare and interact with health professionals. For example, some of that context was actually highlighted in work by Epping and Jordan actually in 2004, and actually there's more in papers by Halamaker in 2000 and team in 2008, and Green and Hibbard in 2012. And so there is that evidence again that shows that the skills can be developed and strengthened even among those who are initially less confident, immunoliteralized, and less motivated, or have just generally feel like they're on the brink, basically. So I want to say thank you for listening. Before I go, I'm just going to shout out a few important references. Hopefully listeners can do their own sort of check out these resources in their own time. So there is a paper by it's a book publication, and if you can still access a library, or you can search this out on the internet, for example. And I'm not promoting this particularly, but It's a good resource to check out. And it's a book by Abbott in 1998, The System of Professions, and it's an essay on the division of expert labor. So it's kind of it does fall into areas of like economy and all that, but it can help, kind of give an understanding or a basis as to why, for example, there's potentially monopoly of particular services and aspects of healthcare, etc. In certain by certain health professionals versus other health professionals, etc., etc. And that's a book publication by the University of Chicago Press. And then there is a book, the paper by Barnett and team in 2012, Epidemiology of Multi-Morbidity and Implications of Healthcare Research and Medical Education, a cross-sectional study, and that was published in the Lancet, and in 2012. There is a really quite sort of an intriguing read around different kinds of health professionals again, and sort of I suppose the digital and online perspective of how health professionals could be sort of more sort of I don't want to really use the word innovative, but they could be more broaden out aspects of health educational support through digital media. And this is a document, it's a framework called a Digital Framework for Allied Health Professionals. It was published in 2019, and if you touch that, if you put that into your search engine, you should be able to get that. It should be downloadable. There's another one that's similar, was published in 2017, and this was This is called Allied Health Professionals into Action, and if you just put that into your search engines, hopefully you'll find that. There is the paper by Epping and Jordan and team in 2004. It is titled Improving the Quality of Healthcare for Chronic Conditions, and that was published in Quality Safety Healthcare, again in 2004. It's a little bit older, but it's quite a good one. The paper by Hanamalka and team in 2008, Early Experiences with Personal Health Records, that was published in the Journal of American Medicine, Journal of American Medical Informatics Association, I think it is, and it's quite a good one. There's one by Green, the paper by Green and Hibbard in 2012. That was why the paper is titled "Why Does Patient Activation Matter?" An examination of the relationships between patient activation and health-related outcomes, and that was published in the Journal of General Internal Medicine. That was in 2012, and there is a paper, a report. It's a report. It is a little bit dated, but it is actually quite a good one. It's called Making the Changes, published in 2001, a strategy for the health professions in healthcare science. That's quite a good one. And there's another paper which is really excellent, actually. It's probably one of my favorites. It's by Nutbeam, who's an Australian author. Nutbeam in 2018, Nutbeam and colleagues, I think it's 2018, and it's titled Health Literacy in Context, and it was published in the internal, I think, Journal of Environmental sorry, the full title isn't given. The journal of the full title of the journal isn't here, but it is a public health journal, and I think it should be available and downloadable. And the Nutbeam in 2000 actually wrote a publication of health literacy as a public health goal, a challenge for contemporary health education and communication strategies into the 21st century. And it's that was actually was published in a Health Promotional International. The paper by Petsulas is a good one. Provides a basis on areas of psychological commissioning, etc., and other areas, and how, you know, money, how aspects of I guess business and focus and quality and quaffs and all of that stuff is highlighted in some of in Petsulas's paper in some regard. And it's titled, the full title of the paper was Primary Care Led Commissioning and Public Involvement in the English National Health Service and Lessons from the Past, and that was that's published in a healthcare journal. And then if I can just, oh yeah, there's the King's Fund report, and this is published in 2018, and it's titled A Vision for Population Health Towards a Healthier Future. And you can just type in a vision for population health towards a healthier future, for example. That should give the King's Fund report, should be downloadable. And the King's Fund did another report in 2013. So before that one in 2018, the one in 2013. And this is a paper, a publication that was titled Delivering Better Services for People with Long-Term Conditions, Building the House of Care, and it's quite a good one. And now finally, I want to highlight there's two other ones, two final ones, and that is there's one by Wu and Liu, and they published a paper in 2017, Online Written Consultation, Telephone Consultation and Offline Appointment, an examination of the channel effect in online health communities, and that was published in the Internal Journal of Medical Informatics, I believe it is, and that was 2017. There's a paper, the final paper is Zikmund and Fisher and team in 2017, and they published a paper on graphics, titled Graphics Help Patients Distinguish Between Urgent and Non-Urgent Deviations in Laboratory Test Results, and that was published in the Journal of American Medicine and Informatics Association, I believe it is. And that's your lot for this audio podcast. I hope you've enjoyed it. I've enjoyed providing some of that sort of evidence-based the best way I can, and sort of making it engaging in one way or another. Thanks for listening, people. That's another episode around the molecular storm gauge. This has been around population health and grouping vasculatures. It's been another Ztorm Lobostics production. It's been lovely highlighting this context. Thank you, and have a good one.